Well, thank you so much, Dr. Yoshihara. For many of you who I've seen before, you know that Kyoto is my favorite city in the world. So I'm very, very happy to be back in Kyoto. When I was here with Dr. Yoshihara for Obon in 2009, I promised I would come back and tell you if the $27 billion we were spending worked or didn't work. Now, I turned to my translator for $27 billion.
すみません、数字の時には通訳が入るというお話でしたので、今申し上げたいと思います。270億ドルの資金調達があり、その調達がうまくいったら、あるいはうまくいかなかったら話をしようということになっておりました。
The yen is too strong. Good for you, bad for me. When we started this program in 2009, to spend $27 billion, you need guiding principles, ideas that would steer that money to be spent wisely and quickly. So we allocated the money to a series of programs which I'll describe, each of which had specific measurable outcomes. We allocated money, as you'll see, to states and local governments. Because just as in Japan, we have a central government, and then we have local governments such as a prefecture government or a ward, and sometimes money can be spent most wisely locally rather than nationally. We wanted to use technology that would work, but at the same time, we wanted innovation. So you'll see some money was spent on existing technology and some spent on research. And finally, we wanted to spend money in cities, but also in rural areas. So when I think of Japan, I was recently meeting with government officials from Iwate Prefecture, and they described a low population and many agricultural areas. In the United States, we have very similar differences between Massachusetts and North Dakota. We want to make sure every state has technology and not just the major cities and academic centers. So we allocated that $27 billion on several programs. And I've outlined some of them here. So first, we established regional extension centers. Now that's a very funny term. It actually doesn't make any sense in English. This idea came from the 1920s in the United States. Farms were not very technological. So the United States created experts in each state and city to train farmers to use technology to grow crops better. So in 2009, we decided to use the same idea, create experts in every state and locality to train doctors to use technology better for healthcare. As you'll see, we spent about $500 million on this, creating experts at what would be the prefecture kind of level.
はい、こちらのように数字が出ました。このリージョナルエクステンションセンターなんですけれども、これは週ごとにエキスパートを配置をし、そして医師に対して、技術、IT の技術を駆使することができるような、そういったシステムを作ろうということで掲げられたセンターです。これにかけた金額は5億ドルとなっています。
Now, similarly, we spent about $600 million on health information exchange in each state. Now, I think of Dr. Yoshihara's Dolphin project. We have in each state different privacy laws, different community needs. And so by allocating money to each state and simply asking for a result, a goal, not telling them what technology they had to use, but telling them they had to automate medication, laboratory, and clinical summary exchange, we feel will have the greatest likelihood of success. I will show you some slides as to how well we're doing.
そしてこの一番グラフの下の方にありますこのエクスチェンジという部分ですが、情報の交換をするこの部分でかけたお金が6億ドルにまたがっています。これは吉原先生のドルフィンプロジェクトと同様に州ごとでもちろん法律も違いますしニーズも違います。そうした州に対して一定の資金を差し出し、そして結果を求めていくというものであります。どの技術を使いなさいという押し付けはいたしません。しかし自動化をしなさいということでメディケーション、ラボラトリー、クリニカルサマリーエクスチェンジなどのプロジェクトを起こしてゴールとしてはそれを成功させてほしいということで州に対して資金を調達するという考え方です。これに6億ドルを費やしました。
But this program, the Regional Extension Center, and this program, the Health Information Exchange activity, supports what is the major activity, $25 billion spent on incentives for doctors and hospitals.
そしてこの上にありますリージョナルエクステンションセンター、そして下のこの交換のエクスチェンジのプロジェクトを介しまして、私たちが実際に求めているのはこの真ん中にあります意味のあるこの利用とミーニングフルユースというこのコンセプトであります。そして実に250億ドルがこれにかけられ、インセンティブを医師に与えてこれを採択し実行するようにという奨励を行ったという考え方です。
So as I told you in 2009, what we decided to do was not give doctors and hospitals money to buy technology. That might make software and hardware companies very wealthy, but it might not result in doctors using technology wisely. The idea of meaningful use is doctors and hospitals have to buy the hardware and software themselves, and they only get stimulus money. They only get part of that $25 billion when they have demonstrated they are using the technology wisely. And we have objective measures, 25 objective measures of the use of technology. So as I'll go through some detail, I'll tell you that this meaningful use idea has worked very well in the United States. Probably the best measure of success is listening to doctors and researchers over lunch in the cafeteria. When a doctor says, "I have changed my office because I am working on meaningful use," then you know your policy has had an impact. Our goal is 5 years long. 2011 is a goal to place electronic health records in every hospital and every doctor's office. Now, as I told Dr. Yoshihara, I have never been a patient in Japan, and I am not a doctor in Japan. So anything I say about Japan is purely an opinion based on what I have seen or others have told me. In the United States, we do not have standardized health care. You may go to one doctor and get very low-cost care that is very effective, and you may go to another doctor and get very high-cost care that is not effective and unnecessary. So in 2013, our goal is to standardize care processes with decision support so that doctors, when ordering medications or labs or radiology tests, are told what is the best test for a given patient symptom or complaint. I have Japan also has issues with non-standardized care across its hospitals and doctors' offices. By 2015, we hope the use of electronic health records and health information exchange and decision support results in better outcomes. People have better wellness. They are more healthy. So our meaningful use regulation, this notion of paying doctors and hospitals only when they achieve a good result, was first published in July of 2010. You'll see we have already enrolled 35,200 doctors in that program. Now, do you want to translate the 35,200?
これは必要ないと思いますが、35,200名の医師、医療従事者の方たちがこのレジストレーションプロセスに参加されています。
Now, we are spending billions of dollars. The program first allowed doctors to claim they had achieved the federal goals in May of 2011, and thus far, $64 million has been paid to 480 healthcare providers in 6 states.
そして最初にこのメディケアの支払いがなされましたのが今年の5月ということで、この時点におきまして実際に支払いがなされましたのが、いわゆる刺激策として支払いがなされましたのが6つの州にまたがる480名の医療従事者に向けてでありまして、額は$6,400万となっています。
So my hospital, Beth Israel Deaconess, was the first hospital in the United States to achieve all of the goals of the federal government, and we received $2.6 million this year, and we will receive $2 million each year for the next 4 years in recognition of our advanced IT systems.
そして私が所属しておりますニューヨークの病院でありますが、一つのビーコン、いわゆるそのパイロットとして成功しているその他の病院に対して手本となるような位置づけの病院でありますけれども、今年$260万を、受けました。そしてこれから先4年間毎年$200万がこの IT の優れた IT の利用者としてその認識のもとにこの資金を受けることになっています。
So thus far, as of August 2011, while I'm in Kyoto, 81% of hospitals in the United States have applied to participate in these electronic health record incentive programs, and 41% of physician practices have applied to participate. Okay? Now, I promised in 2009 to describe, has it worked? Well, we have begun to publish papers that show you that there is a statistically significant change in the use of information technology in the United States. You can see we've gone from 17% of doctors to 25% of doctors using electronic health records, and in primary care, general practice, we're up to 30%. Now, this does vary by state. So in Massachusetts, where I live, 60% of primary care doctors are using electronic health records. So in fact, we're only at 30% is a reflection that many states in the United States don't have a lot of IT expertise, and many states don't yet have broadband. And so Japan has the world's finest fiber and wireless network. Much of the United States does not have broadband or 3G. We will not allow just any product to be used by doctors. We want products that are good enough. So we established a program called certification that reviews the functionality of each product and determines that it will meet the national goals. So Dr. Yoshihara and I often talk about standards like medical markup language or versions of HL7. And these products, in order to be certified, must use national standards, must be able to exchange data, must be able to protect security. Now what's very interesting, you can see, of the 358 vendors of products in the United States that have achieved certification, 65% are small companies. These are companies creating iPhone apps, innovation. This is not just Fujitsu, Mitsubishi, General Electric. It's 5 people in a garage creating innovative technology. This gives some detail of all of the money that we spent creating a foundation for meaningful use. I've already mentioned the idea of regional extension centers. I didn't mention that we have, typically community colleges have received money to train new personnel. I'll go through that in just a moment. The health information exchange I mentioned. And this is an interesting idea. So I think of Kyoto as a shining light, a beacon, an example for the rest of Japan, because you've done much fine IT work here. 17 cities in the United States applied for grants to be examples of technology adoption that would improve quality and safety and efficiency, and received $250 million in grants to implement new technology and demonstrate its effectiveness. $250 million?
はい、このビーコンコミュニティと書かれてありますけれども、US におきましては17の都市が、いわゆるこの、アプリケーションを出しまして、申請を出しまして、技術を導入し、そして品質を上げる、安全性を上げる、そして効率を上げるということに取り組むということで、名乗りを上げました。そしてこの都市のために2億5000万ドルが費やされております。新しい技術の導入、そしてその運用に対する刺激として出された金額です。
Now, many of you work in clinical informatics. $60 million in grants was given to pure research. Not just cities or states, but researchers like you to innovate. And so Dr. Yoshihara often uses Apple products, like this one. Wouldn't it be wonderful if there was an app store for healthcare IT, and if you wanted a health information exchange, you could just download an app and it would just work? Well, one of these grants is to build an app store for healthcare IT.
そして6000万ドルが本当に純粋にリサーチに向けられて調達されている資金であります。もちろん先ほど申し上げているように市であるとかあるいは州にお金が出ますけれども、皆さんのようにイノベーションでもって技術を革新的に利用していきたいと考えられる方々にもその研究のために6000万ドルものお金が出されているというそういうことなのであります。吉原先生も石原先生もアップルがおそびだと思いますけれども、例えばアップストアなどを例えば立ち上げて、そしてそのヘルスケアの IT を駆使していく、ダウンロードができて、そしてアップストアを立ち上げてこれを利用するというようなことが可能になるわけです。
Now, I promised Dr. Yoshihara, and I promised all of you when I was here in 2009, to be very honest about what worked and what didn't work. I've talked about the idea of regional extension centers. Many states have excellent regional extension centers. They have many qualified IT experts. But many states don't have experts, and they've hired consulting companies. And those consulting companies, some are good, some are bad. And so I think what we'll see in the United States is some of our regional extension centers will actually lose their funding because they won't be able to achieve the national goals. So the federal government has said they will monitor the progress of every state, and if progress is not being made, money will be taken back. So some good, some bad, but generally the culture in the United States has changed such that electronic health records are now seen as an important part of medical practice. So this just gives you a sense of our current enrolled providers and primary care providers, that we're a little over halfway in our progress in getting all of these providers enrolled. The workforce program has worked very well. So we have 3,280 informatics graduates that will be helping doctors implement electronic health records. The hardest part, in my view as a CIO, of implementing electronic health records is hiring the right people to help doctors do the job. Doctors may be very good at caring for patients. They're not so good at selecting software or administrating databases. And so it's very important to train experts that will help doctors transform their workflow. Our Beacon Communities program is very early. It's hard to know if it will succeed or not. I think my belief, some cities will implement all they promised, and we will learn a great deal. Some will have received money, but won't have the expertise to spend it wisely. So we may see some cities not succeed in the Beacon program. This just gives you a sense, and see, next time I come back to Kyoto, I can tell you how well this worked, that the grants were given in 2010. 2011, we begin our first innovative applications, but then in 2012 and 2013, we see if it made a difference. Because just buying hardware and software doesn't improve health. And the hope is that through the use of things like home care technologies, telemedicine, quality registries, that we will by 2012 and 2013 see improved quality and outcomes. To give you a sense of how many individuals and how many sites are involved, those 17 communities include 5,000 medical professionals and 600,000 people, patients, who will receive care from those electronic systems. A number of the communities are working on transitions of care. So the idea when you leave a hospital, your primary care doctor, your general practitioner, will receive an electronic summary of all of your care. Some are looking at more quality and processes. Did diabetics get appropriate treatment so that their sugars are in good control? Did asthmatic patients stay out of the emergency room? Did congestive heart patients stay out of the hospital? And all the communities will be submitting cost, quality, and health data. Now, I've worked with the Japanese government at the federal level and at the prefecture level over my visits in February and my visits this time. I am told, or I think, that if you tell the federal government that cost will go down and quality will go up, the federal government in Japan will be willing to change policy. Sometimes, I think, it's hard to change the federal government just based on quality. Saving money is very important to the Ministry of Finance. So we hope in the United States to demonstrate that we can reduce cost and improve quality with healthcare IT. Now, healthcare information exchange in the United States, probably a bit like Japan, is very challenging. We are making progress. Many of our states have been given special grants to do things like reduce readmission to the hospital, improve transitions, involve patients. I know, for example, with the Dolphin Project, you involve patients in consent. That we try to share data based on patient preference. Maybe the patients don't want all their data shared. And that we create analysis tools to look at healthcare across populations. The problem with health information exchange is in the United States, and I think in Japan, sometimes hospitals are paid to deliver care that is not needed. That is, if I was in Tokyo this morning and got an MRI, and I came to Kyoto and got another MRI, both providers would be paid for the MRI. In the United States, same problem. Health information exchange eliminates duplication. The problem is doctors get paid for duplication, so medical societies sometimes can resist health information exchange because the income of doctors will go down as health information exchange becomes more common. Now, I have heard, again, I'm not sure this is true, that the Japanese Medical Association at times can resist the use of electronic health records and health information exchange for fear of loss of income. Maybe true. I don't know. Japan and the United States have a similar problem. Do you change regulation at a federal level? Do you engage doctors at a local level? Do you try projects at a prefecture level? So this means top down, bottom up, or middle out. And I think in the United States what we've recognized, top down does not always work. That we have said we will do standards, we will do regulation, and we will do budgets at a federal level. But we will have much work done at a community level or a state level because we're more likely to engage doctors, nurses, pharmacists, and patients at a local level. We did have an interesting problem, a technology standards problem. I would tell you so much of the work we're doing in the United States is not about the bits and the bytes. It's more about education and policy. But we did have to make one technical decision. If I want to send my medical record to Dr. Yoshihara, what protocol should I use to send it from the United States to Japan? I could use FTP, File Transfer Protocol. I could use HTTP, such as a REST or SOAP transaction. But he and I, we've been emailing back and forth during my entire stay in Kyoto. No new technology is necessary for my BlackBerry to communicate with his iPhone. I think you still have an iPhone. So we decided in the United States that email, SMTP, is a very simple protocol that requires no new technology. The problem is it is not secure. So we decided we would create what we are calling the Direct Project that allows doctors and hospitals to exchange email with each other using encryption. Okay, this is where it gets slightly complicated. So